Hi, this is Michael Altos, and we're back talking about the coagulation system, and this is part 3. There are a few final drugs we want to discuss in the realm of anticoagulant drugs, and these start with the direct thrombin inhibitors. We're going to talk about some drugs now that I really can't expect you to memorize because I can't even memorize all of them. And I've actually reproduced a chart in your notes, which may be of some reference for you. And these are the kinds of things that I'm looking up in my reference materials or Googling when I'm exposed to them, because there are so many of them and they come out with new ones all the time. But we'd like to discuss some of the basic principles here, and you should certainly be familiar with these drug names so that when you hear them, you start to understand that there are some implications you need to be thinking about. So the direct thrombin inhibitors, remember thrombin is sort of the end of the coagulation cascade, really one of the major players in creating clot. So argatroban, dabigatran, which is Pradaxa, bivalirudin, which is Angiomax, these are all thrombin inhibitors. And they also have some function by suppressing platelet function. These drugs can be a good alternative to heparin, and that might be useful if you have a patient with the heparin-induced thrombocytopenia. It's been used for cardiopulmonary bypass and for ECMO. It's been used in treatment of acute coronary syndromes in these patients who can't have heparin. I've used it in the management intraoperatively of a patient who is having a carotid endarterectomy. And usually these drugs are administered and then the PTT is measured and dose is titrated based on that. If the drugs need to be reversed, there isn't a lot of data for reversal of any of the drugs we're about to talk about, but prothrombin complex concentrates seem to be your best choice. There are also some direct factor 10A inhibitors. These drugs all have X's in them. Of course, there are drugs back here that also have X's in them, so that's not really a reliable rule. But these are drugs like Xarelto and Eliquis. These are drugs that have very short half-lives and a rapid onset of action, so there isn't a lot of monitoring necessary. And there really aren't any dietary restrictions or interactions. These can also be used for patients who have HIT, and again, probably would be reversed with prothrombin complex concentrates if an emergency would arise. There are also some indirect factor 10A inhibitors, and the most common one is fondaparinux, also called Arixtra. This drug mimics the active binding site of heparin, and so it will bind to antithrombin 3, but it also inhibits factor 10A without inhibiting thrombin. The risk of HIT in these drugs is quite low, and in general they're considered an alternative when patients have HIT. They can also be used for the prophylaxis and treatment of DVTs or PEs. There's really no data about how long these drugs need to be stopped before you can do regional anesthesia. Most people wait 24 to 48 hours. They're excreted renally, and reversal may be best with factor 7A. Here's that chart I was talking about that just has a list of a number of different anticoagulants and antithrombotics, and this is in your notes just for your reference. Take a moment if you have any questions you want to jot down, and then we'll move on. So we've talked about a lot of drugs that will thin your blood and make you bleed. And now we're going to talk about a few drugs that will do the opposite, that will actually prevent bleeding. The first class are the anti-fibrinolytic drugs. These are drugs that might be used in the operating room or after surgery to decrease bleeding. And they've been used in every kind of surgical situation you might imagine, whether it's cardiac or liver surgery, in transplants, in orthopedic or pelvic surgery, obstetric emergencies, craniofacial surgeries. The way these drugs work is by forming a complex with plasminogen. And remember, we said plasminogen gets activated to make plasmin, and plasmin busts clots. So if we can make a complex with plasminogen and prevent the plasmin from being activated. And furthermore, if we can inactivate the plasmin that's already been activated, then we can't bust the clots. And in fact, these are anti-fibrinolytic drugs. They prevent fibrinolysis. Basically, they stabilize clot. And as you could probably guess, the biggest risk from these drugs is formation of clots. Epsilon aminocaproic acid, called Amicar, and tranexamic acid are the two anti-fibrinolytic drugs you're most likely to run into. And like we said, these are clot-protecting drugs. They prevent plasminogen being converted into plasmin, and they inactivate plasmin that's already been activated. Side effects of Amicar might include myalgias and nausea. And tranexamic acid, as I said in the last slide, has been used for a number of different indications. One example at our institution is we now use it routinely for joint replacement surgery. We give people a 10 milligram per kilogram bolus after induction of anesthesia or spinal anesthesia. And it's given prior to incision, and it's given over about 10 to 15 minutes. And 3 hours later, the dose is repeated, unless the creatinine is elevated. And we choose not to give this drugs to patients who may be harmed seriously by a thrombotic complication. So these would be patients who have a history of a DVT or a PE, of coronary disease, or a coronary stent, or a stroke, or other prothrombotic conditions. There used to be a drug called aprotinin. I don't think you'll see this on exams anymore. It's off the market because it seemed to increase the risk of MI and also renal failure. Okay, take a moment and consider if you have any questions that you need to discuss, either by email or you can bring them to class. Now we're going to get into some of the expensive drugs out there. The first is recombinant factor 7A. Now, we haven't really reviewed the coagulation cascade, and I don't intend to review it as part of this course. But factor 7A is right in the center of a lot of the action. Factor 7A directly activates factor 10, and factor 10 initiates the thrombin burst. This is important because it bypasses the need for factors 8 and factor 9. All you need is some factor 5, factor 10, which activates the burst, factor 2, which is thrombin, fibrinogen, and some platelets. And if a patient has those things, then factor 7A will work well. So originally this drug was developed to be a treatment for hemophilia, because since it bypasses factors 8 and 9, and that's what hemophiliacs are deficient in, that's what it was originally developed for. But it's become the last resort agent for hemostasis during an emergency. And it's been used in traumas, hepatic failures and transplantation, GI bleeds, OB hemorrhage, intracranial hemorrhage. People have routinely used it to reverse warfarin in an emergency, but that really seems not to be recommended anymore. Nobody really knows the right dose for this drug. A lot of people will start with 20 to 40 micrograms per kilogram if it's a non-emergency case. If it's a more urgent situation, they may double or triple that dose, and continue repeating until you get to about 200 mics per kilogram maximum. Just as an aside, if you are giving this for a hemophiliac, which we don't really do that anymore because we can get recombinant factor 8 or factor 9. But if you did give it to a hemophiliac, the recommended dose is 90 mics per kilogram. And you'll be happy to see that the drug has a half-life of 2 hours, so you'll probably be redosing it. And that makes the manufacturer happy because it costs $1 per microgram. So if you're giving somebody 90 micrograms per kilogram, and they weigh 100 kilograms, so you'll be giving $9,000 worth of drug, and the dose needs to be repeated every couple hours. As you are probably going to guess, these drugs can cause thrombotic complications like stroke, MI, PE, and clotting of devices like an ECMO or an LVAD. And caution should also be exercised in patients who have coronary disease, cerebral vascular disease, and patients who are in DIC. A newer drug that's becoming more widely available in major centers is PCCs, prothrombin complex concentrates, also FDA approved for treatment of hemophilia, but becoming the drug of choice for emergency reversal of vitamin K antagonists like Coumadin, and management of critical emergency bleeding in surgery, trauma, and liver failure. There seem to be a lot less of those thrombotic complications with PCCs compared to that factor 7A, and less risk of infection than you might get from pumping somebody full of FFP. Usually, PCCs contain factors 2, 7, 9, and 10. Those are the vitamin K dependent factors, and also some kind of an anticoagulant. There are different formulations of PCCs. One of them lacks factor 7, which was the one available in the US most often, but that may be in the process of changing if it hasn't already. And keep in mind that factors 2 and 10 have half-lives of 60 and 30 hours. So unlike factor 7, which needed to be redosed every couple hours, PCCs you may only need to dose one time and be done. And if you think you need to give a second dose, you should probably check a thromboelastogram or some other detailed study of the coagulation in your patient before drawing up another dose, because this is also an expensive drug. And like factor 7A, it shouldn't be given to patients who are in DIC or have a high risk of thrombosis. Finally, just as a little catch-all here at the end, I wanted to discuss Desmopressin, DDAVP, for just a moment. This is a substance that causes release of factor 8, von Willebrand factor, and TPA, endogenous TPA. It's most commonly used in the treatment of von Willebrand's disease, and it's in fact the treatment of choice for all except a certain type called type 2B. Other patients who benefit from Desmopressin include mild hemophiliacs, patients who have uremia from kidney failure or other causes, because the urea impairs platelet function, and patients who are taking various medications that impair platelet function, like aspirin and other NSAIDs, dextran, and Plavix. Now, DDAVP, the VP stands for vasopressin, and this is an analog of vasopressin. It has activity, though, just at the V2 receptors, which means that a lot of the things we associate with vasopressin, like vasoconstriction, don't occur. It really works just on the antidiuretic receptors. Desmopressin usually lasts for about 6 to 8 hours. With that, I think we've covered all the major points in the pharmacology of the coagulation system. If you have any questions, feel free to contact me. Otherwise, I will look forward to seeing you in class.